Thank you, Dr. Thrasher, for that presentation. I really enjoyed hearing about the value of Wish and Pulse and Patient Ping in your environment. So Dr. Thrasher has joined us live for some interaction with the audience. We do have a question or two that's come in via chat, and Steve has that, and we'll ask Dr. Thrasher to engage on it.
Thanks again, Dr. Thrasher. The question is, how is consent to share records being addressed in the rescinding of consent? So we think the intent of this question is, how is Milwaukee County Behavioral Health Division receiving patient consent to share, understanding that today the Behavioral Health Division is not yet contributing data to WISHN. That's an ongoing active project. But Dr. Thrasher, could you address how you and your staff are documenting the consent to share patient information?
It's a great question and very pertinent to patient privacy, patient rights, and everything else that goes along with these technological advances. So as you alluded to, the very short answer is we currently are using the product, but we are not fully sharing any information back. So as that is being considered, like you said, future state and new developments of the Behavioral Health Division, which is transitioning a bit, we're going to have to work that into our workflow. Currently, there's a myriad of consents that people go through when they present to our emergency room, as with any other consents on all sorts of items, such as information sharing, where dangerousness plays a role, et cetera, et cetera. So we work all of that in the very beginning of the introduction. But as far as really looking at 42 CFR and other things such as that, we are not currently sharing data back to the WISHN system. So as that progresses, we'll have to work that into our flow.
Yeah, and if I may, I'll just add a little more commentary there. There is no 42 CFR Part 2 data in the WISHN system. That's explicitly prohibited. Our data contributors are prohibited from sharing that kind of information, specifically because there are unique consent requirements that apply to that kind of data. So the kinds of data that require an extra level of consent are just not part of our environment right now. We're hoping that the regulations relax a little bit and recognize that clinical data of all types is really important for care coordination and clinical decision making. But at this point, we're just not allowing that kind of data into our system. In terms of consent in general, everybody on the WISHN network has to stay within the lines of HIPAA, obviously. And HIPAA does allow sharing of clinical information without explicit informed consent for treatment, payment, and operations. And so that's certainly within the bounds of the use of data within the WISHN system. We do have some clients who administer an extra layer, I guess you might say, of patient consent if they wish to. And so they might ask their patients to explicitly allow them to share data with WISHN. That's not legally required, but some of them feel more comfortable doing that. And so that is certainly an option for any data contributor if they want to administer that kind of extra level of consent. That's something that they have the option to do.
I would also add to Joe's point of 42 CFR Part 2 data being explicitly not allowed explicitly in our system. We have two organizations that have authorizations but not yet contributing that Part 2 data into the system. That's DHS, Division of Treatment and Care, DCTS, and the OCHN facilities, or the FQHCs, safety net clinics that are using OCHN. So we will soon see that data flow.
Good point. But there's a way to get around that, but it's a little complicated. Right?
It is. And there's explicit authorizations and forms and to that question. Great question. We do have a couple more questions coming in. I'll ask this one of you, Dr. Thrasher. You mentioned the importance of sharing data back to outpatient providers after an event. How is that achieved if not through Wishin?
So there's a lot of different ways to do this. The Wishin way definitely streamlines it and makes it a lot simpler. We also believe very strongly, as I alluded to in the presentation, in the idea of the follow-up. Oftentimes, so much attention is paid to the crisis, and understandably so, that there's not enough information paid to the after effects, which we know all about in the rest of medicine. It's very important after you have survived a heart attack, they don't just shake your hand and say, have a good day. There's cardiac rehab, and there's extensive follow-up that actually decreases morbidity more than anything else. We try to do the same thing when paralleling a psychiatric crisis. So we have follow-up teams. We know that there's a huge risk for significant decompensation and or safety issues within the first 5 days of leaving a hospitalization. So we follow up in that time period. And we also follow up with all of our ER visits. We have a separate team that we utilize called Team Connect that is a mixture of a clinician and a person with lived experience. And they reach out to every single person that has left our hospital or emergency room, usually within the first 24 hours, if not the first 48. And then what happens is we kind of gauge their needs, make sure to what they have. We then find out about their outpatient providers, and we connect with them as well. So really what we kind of see ourselves as trying to connect the person and their outpatient long-term support agency, make sure they all knew what happened during the crisis, and then we can gracefully kind of back out until needed again.
Thank you for that. We have a couple more questions, and this question, maybe part one answered by you, and then part two is we can carry it on into the conversation with patient ping at 11:10 this morning, is how does patient ping work in the psychiatric setting?
So I think it's one of its biggest benefits there is we have a lot of patients. I don't know the exact percentage, but a very high amount of our high acuity presentations, people that have the most symptoms and have the most effect from those symptoms on their daily life, that are involved with case management. And that's a word that gets thrown out a lot, and it's somewhat nebulous, the idea of a case manager, because they all have different roles. And depending upon what type of case manager you are, you may have more or less contact with your client throughout the average month. For a lot of our patients, they're working with their case managers on at least a 5 days a week, if not 7 day a week basis. So where patient ping really comes in is that relationship. So if you are a case manager and you're working with somebody every single day and they end up in an emergency room somewhere and you don't find out about it till 2 days later, your ability to assist the client or to assist the system that's assisting the client is diminished. So the real place that ping is really, I think, hit it off in our particular system is connecting the patient when in crisis to the case manager. And what I've heard from many emergency medicine physicians is they just like, then all of a sudden the phone rings and like, hey, I hear that you're working with Tony and he's in there for such and such. Can we be of any assistance? That type of connection goes a long way. And given that, as we all know, an emergency room visit can be very time limited, the more we can hurry that up and streamline it via patient ping, I think you're going to see better outcomes. The patient's going to be more satisfied. The treatment team's going to be more satisfied. And as someone who's worked with a lot of case management agencies, I know they would much rather hear about the crisis in the moment via a text or a phone call or however they've set up their ping than finding out about it 3 or 4 days later.
That's great. That makes a lot of sense. And as you mentioned in your presentation, that ability for somebody on the distant end managing that care that's outside of your 4 walls, and they can contact you saying, you have my patient, this is what we're doing with this individual, or please follow up with me directly. That continuity really becomes evident and real.
And for a lot of patients too, they've noted patients feel protected by that. They feel good. They like knowing that there's a lot. I think one of the hardest things, at least when you're in a psychiatric crisis, is feeling of despair and disconnect. Like you don't have anybody and you truly are kind of floating out there on your own. And I think it may be a secondary outcome of it, but it kind of reminds the patient of how connected we are and how much effort there is put in to being there for you when you need it, even if it happens to be 11 p.m. on a Saturday night.
Right. Many other questions that come to mind. One question in the 2 minutes we have left here. All of the data that exists in Wishin helps you in various ways, helps your care coordinators, helps you manage the individual in that crisis situation. What other types of data are you finding that's missing in Wishin that would elevate the experience for you and the care coordinators at Behavioral Health Division?
Yeah, I think one thing that separates, I spent a good part of that presentation kind of showing you the analogs between a psychiatric ER and a medical ER, those that are the similarities and those that are the differences. One of the differences may be that a lot that come to us have many external stakeholders, even beyond that of case management. And the one that I tend to think of most frequently is law enforcement. And part of that may be because of need. Part of that is simply how the Wisconsin state statutes are written. That whenever people are in crisis or facing an involuntary hold or a temporary removal of their civil rights, law enforcement must be involved. Not should be or could be, but must be. So they are a regular shareholder with us. And I think down the road, that would be an interesting component too. I know there's probably some things to work out there. Some interesting probably arguments, both pro and con, but I just can't stop but thinking how often a lot of our patients' first contact in the environment is with law enforcement. And while we are working on different ways to be the first provider, if it is law enforcement, is there a way that we could tie in their information or have our information known to them so that they know different things like safety plans, best coping mechanisms, et cetera, et cetera?
Thank you, Dr. Thrasher. That was very interesting. We appreciate your passion and your commitment to the patients that you're serving. And we look forward to bringing on that data in the near future into the network, according to the restrictions that you guys work out. But I think everybody will benefit, especially in the Milwaukee area, if we can present a more complete clinical picture when your folks might be visiting some other emergency room, for example. So thank you very much. We're going to move on and